We're ready for a CCO Club webinar. It's number 95, and the club webinar is where we get questions from you and then we answer those questions. So tonight we have an excellent question regarding, oh, well, my thing didn't jump. Hold on. Critical care changes for the COVID patient. It's a new year, 2022. This isn't going to be evergreen because there were some major changes for critical care and coding out critical care. And what do we have the most of right now that everybody's thinking about is in regards to COVID patients. So we're not going to talk about the ICD codes. That's what I love the most, and that's what I really like to talk about. However, we're going to talk about those critical care codes. There's really only two. So there have been some changes. We're going to break down those changes, and then we've got a couple examples that came out from CPT Assistant and in regards to as if they were a critical care COVID patient, and we're going to answer those questions through the question and answers through the CPT Assistant. Don't forget that the CCO Club is where you will get the transcript, the slide deck, as well as having access to continued conversations with this topic. I look forward to hearing your comments and seeing your topics, your questions and thoughts in the club as we move forward. Those critical care codes, which are the codes that we're talking about? That is 99291 and 99292. Keep in mind that 99292 is an add-on code, and what is most helpful for you if you ever write these codes down, whenever you come to an add-on code, make sure you put a plus symbol in front of it. In fact, that would have been a good idea for me to go ahead and put that plus symbol in front of there because it is not a standalone code. For any of our listeners who are students and just learning the coding, when you have an add-on code, that means it is in addition to the parent code. So the parent code here would be 99291, and then to tell the rest of the story, it would be 99292, which usually constitutes for CPT sizes, more diameter or time being in addition. Now, what is the critical care code we're talking about? This is evaluation and management for critical ill or critically injured patients. The 99291 will cover the first 30 to 74 minutes. And then in addition, each additional 30 minutes would be listed on top of that. So if you had 74 minutes, would be the first code, and then you had another hour on top of that, then you would use the 99291 by itself because that's the parent code, and then you would use 99292 times 2, or just write it twice, use it twice, depending on how your payer wishes to have it put on the form. Keep in mind that CMS reversed some of its thought process for 2022. They were going to bundle critical care visits with global surgery codes, and they weren't going to increase payment, but they realized that this was going to be very problematic, and the stakeholders kind of got up in arms, and so they pulled back the reins on that. In other words, there were some other changes. We're going to talk about those changes a little bit. First, they have the split shared EM visit. You're probably going to see it most often written split shared. The definition of this is a visit provided in a facility setting in which a physician and an other qualified healthcare professional, which they will abbreviate that QHP, jointly provide the face-to-face and non-face-to-face work-related visit. Now, this is all per cms.gov. I can see you guys commenting over. Sarah said, do you think the new vaccine status will allow payers to reduce payment for all COVID care unvaccinated versus vaccinated? Probably not. I don't think so, Sarah. But thank you for asking that questions. But I don't think so. I don't think we're going to see a difference on that. Uh, uh, but I could see where you're thinking in the thought process that would come from that. And we've got somebody watching from the Philippines, and I don't know if it's Gian, but hopefully I didn't mispronounce your name. So what two models are options here with the split shared? We have more than half of the total time spent. Now, E&M changed because it's based on medical decision making or time now. That was a major change. And so this is reflecting that. So if you have more than half of the total time spent can be documented, or one of the three key components, and that would be the history exam and medical decision making. Okay. So what does it look like with the documentation? What do we have to do to document that? You're going to have to, the providers will need to identify who the qualified healthcare professionals are. Now, this could be a physician and an NP or a PA, or it could be two physicians, two different specialties, which we've got an example of that here in just a second. And then that has to be documented. In addition, is who performed the substantive portion. And this word is used again and again and again for this description. And that would mean ultimately who did the bulk of that. Now, there is linked at the end the resources that I use, some great articles that were written, and it gives a lot more description here. Go ahead and feel free to look at that. You can go out to cms.gov also and look it up. But I kind of like this one particular article, how it was written. It defined it a little bit better with the bullet points, easier to read. And again, I'll mention that at the end so that you can reference that. It's really easy to reference it again if you're in the club, right? What about that split shared visit? This is the statement that's made. But ultimately, when we look at this, now I'm just going to highlight a few things here. When it's an E&M visit and it's like we said, institutional setting performed by a physician or NPP, which is a non-physician provider in a group, same group, then they stated that the scope has to include new and established patient, initial, subsequent visit, critical care visits, prolonged, et cetera, et cetera. The provider who performs the sustainative portion, and it has to be more than half of the visit, would bill for that. And it went on to state which can be based on history exam or MDM or total, except critical care services, which must be based on total time. That's pertinent, and that's why I wanted to highlight that and underline that. And then it goes on to talk about overlapping time spent by the providers and how to divide all of that when you do split shared visits. Well, the next thing that you need to be aware of, though, is that when you have your critical care services, they can be furnished concurrently with other providers. So you can have the same patient on the same day by more than one practitioner representing more than one specialty. Now, the example that I found in another article that went on to say you're looking at those two codes, the 99291 and 99292, which are your critical care codes, and the time, but it went on there to say, kind of in the middle of that green box, non-continuous times would be aggregated. And then your critical care services could be furnished concurrently to the same patient on the same day by more than one practitioner in more than one specialty, provided that is not duplicative or other services and meets definitional requirements. Now, when you take out the fancy speech and stuff, is saying that if you have one provider that does the history, the exam, and the medical decision making, uh, uh, and then, or you can't have another one that comes in and does those exact same things. That's duplicating the process. However, in critical care, but you could have one that does the history exam and the other one that that pulls out the medical decision making. Then you're not duplicating that. But when you're dealing with this, the documentation has to be very specific on who does what, or it will not get captured for critical care. The It's got to be able to pass the audit. Now look in the purple box. It says, okay, if you have providers in the same specialty, in the same group, they can provide concurrent follow-up critical care on the same day, provided they use the code for subsequent time intervals, meaning they're going to use that 99292 once they get over the 74 minutes. Time spent by more than one practitioner in the same group with the same specialty would be combined for purposes of meeting the time requirement. In other words, you can add that time together. So Dr. Feelgood comes in and spends, 80 minutes with the patient. And then Dr. Slaughter comes in later that afternoon and spends another 30 minutes. Then you're going to be able to use that add-on code for the time, the 10 minutes, or 6 minutes that was over, plus the 30 minutes that the second provider did, because it's the same provider, same specialty, etc. And I wanted you to know that again, the documentation and who does what has to be very detailed. This is where they're going to come back and they're going to say, well, honestly, because our providers haven't been trained in this. They're used to doing it one way, and they're still struggling with time and medical decision making, thinking, oh, this is really easy. Now all I have to do is that. But it is not the case when it comes to multiple providers working, especially in critical care, with one patient. In addition, if you're going to have the same day, and this is just kind of a repeating of what we just said, but it goes on to say that if you have your provider document that the E&M visit was provided prior to the critical care service at the time when the patient did not require critical care, or the visit was medically necessary, and the services were separate and distinct with no duplicative elements from the critical care service later that day, then you could use the modifier 25 to state that in the report. Now, in the green box I found in another article, they had stated, no other E&M could be billed for the same patient on the same day as a critical care service by the same practitioner, because then you're double dipping into this. So if you have practitioners of the same specialty, the same group, you can't do a E&M that's not a critical care and then add a critical care on top of it. It's not going to work. So if that is the case, then you can do the visits as split shared visits, and be very careful about CMS, what qualifies as critical care. And you can look at pages as of 2022 in your CPT manual. Pages 31 through 32 will give you more insight into what constitutes critical care. Okay, and this would be something, if you are educating your providers about what needs to be documented, documenting tips and explaining these changes to them, that's where you're going to go to get the information. 2022 Coding Manual, CPT, page 31 and 32. Now, these changes are brand new for 2022. So if you are watching this later and you're saying, wait a minute, I can't find that. Well, in 2023, it's not going to be on those pages. But chances are there will still be changes. So 6 months from now, CMS could change this whole idea again. With that being said, I've got a note regarding what could be changed on not this slide, but the next one. Let's see, they're talking about in this bullet, pre-operative and post-operative critical care can be paid in addition to the procedures if the patient meets the definition of critical care criteria. And also, the example they gave would be things like trauma and burn cases where they would be needing procedures to be done. Now, they could create a modifier for specific claims, and you're going to have to be very mindful of what individual payers want as well. This is where I iterate with in future rulemaking. So as of right now, when we're airing 2022, the beginning of the year, your providers could be required to document the total time for the care, right? And they're provided the role that they played in the care. And if there's another provider, that has to be documented, and their role has to be distinct as to who did what and when and why. And then they would attest to those being medically necessary. Okay, if a reversal of this proposed policy, CMS will not bundle critical care visits with global surgical codes, but may consider changing it up with the future rulemaking and adjust or tweak the critical care. But as it is right now, this is what they stated they will do. We all know that CMS likes to change things, but it sounds like as of the time, we're in January, that this is the way it's going to go, which actually, if we can get our providers to document properly, is going to be just fine. Let's look at some scenarios as it would relate to COVID. So with our COVID-19 patients, they would be seeing a pulmonologist, a pulmonary specialist. And one of the first things in the documentations I've been reading and stuff that happens to some of our COVID patients when they go downhill, that they are not surviving, their kidneys start to fail. So what are they going to do? They're going to be bringing in nephrology. In this question that came out, said in the E&M guidelines for critical care services, okay, for 2021 code set, it's unclear how to report code 99291 for initial critical care. Then it said the examples would be, we have physician A, whose specialty is nephrology, spends 45 minutes with the patient and bills the code 99291. And the same day, physician B, who's a pulmonologist, spends 50 minutes with the patient and the time is not overlapping. So you have your you have your nephrologist that spends 45 minutes and you have your pulmonologist who spends 50 minutes. Now, as of 2022, we can go up to 74 minutes for that parent code 99291, and then anything above that would be used. We could do the split share, and we could add on, because we've got we either have to be in the same specialty or we can have two separate specialties working. So the question is, if the physicians are in the same group practice but different specialties, can they both report the 99291? What do you guys think? With the new rules, can they or can't they report? What do you think? And Whitney says, I also have one provider in particular who wants to charge critical care on a patient with a cold. She drives me nuts. Okay, yeah, you can't do critical care with a patient that has a cold. However, if you have a patient that has emphysema and multiple comorbidities, emphysema with an acute respiratory infection, and they have acquired COVID and they already have, say, CKD and some other things, yeah, then maybe you can. But a cold is not the same as COVID either. So I can see how that can be uh, uh, really problematic. If for providers who are documenting 300 minutes of critical care, of course, insurance will not cover that much. Absolutely not. They won't. What would your advice be on dealing with these providers? They're going to have, it's all going to be in the documentation. Now, they can attempt to bill that stuff out, but if we're not in an acute, setting, then probably, like you said, that's not going to get done. But okay, pediatric patients with no other conditions, yeah, that's not going to go critical care. So CPT assistant went on to say, yes, it's appropriate for physicians from different specialties to report the code, critical care NEM for critical care or critically injured patients, first 30 to 74 minutes. And note that there are some third-party payer guidelines that are going to differ from the CPT guidelines. Now, one of the things that was also changed that is noted on all the articles you'll see for 2022 is that for critical care, CMS chose to adopt CPT's verbiage and definition, whereas before they did not, of these codes. And so that is going to be helpful. But when you've got third party payers, they're still kind of doing whatever they want, right? They have the ability to say, well, that's not the way we're going to do it. I doubt you're going to have, but as everything transitions that first year, you may have troubles. And then it goes on to say that for reimbursement or third-party payer policies, contact the appropriate payer. That's just a given, right? You need to know that it's a way of life to know what they've decided to do. And they can, again, change their mind also, right? So they can say, okay, we're going to do this working out January, February, March. And then guess what? April, you know what? This isn't working out. Our policies are changing. And so it is important to have that liaison and that open communication for the payers, or you're going to struggle. The other question that came out that could be related to our COVID patients is when you have a critical care patient and they fail to improve and the decision is made to withdraw support, uh, can critical care codes be reported for or during the withdrawal of support if the physician or the qualified healthcare professional provides comfort care during the transition? Now, comfort care would end up being like palliative care is probably what it's going to the verbiage that's going to be used. So you have a COVID patient with respiratory and renal failure, no longer responding to treatment. Decisions made to take the patient off life support and just offer palliative care, or again, not even taking them off life support. They may not have been on life support at that point, but the family or the patient has said, I'm done. And they want palliative care from that point. Palliative care and hospice are two separate things. Okay, um, uh, make sure you understand the definition of the two and how they work together and how they're different. But again, what would be the scenario of a situation like this where we have our COVID patient, they're in respiratory and renal failure? Now, if you're in respiratory failure, you're most likely hooked up to some type of machine, but if you are at that having difficulty, maybe the patient has a form already with the facility that says, do not resuscitate, or whatever their decisions have been made where they don't want to be intubated, or, et cetera. They just want the palliative care. What are we going to do? And that the CPT states that when you have withdrawal of support, it does not mean the service components anymore of critical care. So you cannot use those codes at that time. So once that transition has been made to withdraw that care for the patient, you don't use 99291. You can use that up to that point, but it would not be appropriate to use the 30 to 74 minutes of critical care E&M if once that decision's been made. You would in turn use 99231 through 99233, and these are E&M codes that would be appropriate depending on what work is performed in the palliative care that's being given to the patient. Okay. Can a provider bill critical care if all he does is pronounce the patient as long as critical care time documented? He didn't perform CPR or anything else. Can the provider bill critical care if all he does is pronounce the patient? Is he pronouncing the patient deceased, Whitney? Uh, if that's the case, then no, they can't. And uh, there is scenarios in there regarding uh, CPR being performed. Now, if CPR is performed and the patient recovers and they get vital signs again, then you can do critical care. But if the patient is deceased the no, it the pronouncing that's not critical care. Um, they from my understanding of what I've read, and there was some information regarding that. There was a question that had come up in CPT Assistant, I think, but it wasn't quite related to the COVID and stuff, so I didn't pull that out. But it was stating that if the patient dies and they wanted to know would CPR be covered, and if the patient comes to and regains its vital signs, they stated then it would. But if the patient succumbs and does not recover, then it would not be critical care anymore. And I think that is it. So, any other questions that we might have at the last moment? If not, I wanted to let you know here are the CPT Assistance articles that I found. I did pull them through my Find a Code and subscription that we have through Find a Code, but it also categorizes them for you here. And then I used a couple articles and HK Law to get some of that information. If you choose to use Find a Code like we use, you can get a discount with Find a Code by using cco.us/find a code. I really, really like the way they're set up. They're so easy to navigate, and all of my references like CPT Assistant and I got multiple things as coding clinics and stuff are right there. And so again, we vetted them. We really like them. I hope this was helpful to you. You know that anytime you guys have questions, put them in the club. And if you want to see us use them in a club webinar, then we'd be more than happy to do that research for you. Because if you're asking, then I'm sure it's something that other people are wanting to know. Sherry says, is the assessment part of the MDM if you're using MDM as your key component? Yeah, the assessment is part of that, and that goes back to that first slide. But there is a further breakdown. You have let me just go real quick back because I know it's in that first one here, I think. Well, the split shared, but it divides it up right. It has to be based on the history, exam, and medical decision-making time. So yeah, that would fall in there. The assessment ends up being part of the exam, is their assessment. Usually in the stuff that I read, they combine that there. You're welcome, guys. Okay. And thank you so much for joining us. And we look forward to seeing you at our next week. We've got several topics coming up I think you're going to enjoy. All right. Thanks, guys. Bye-bye.